Good evening. A warm welcome to all of you to Empro's first Author in the Zoom. I'm Jerry Donahue, Vice President of Education for Empro and the moderator for tonight's program. We do ask that you all be on mute. We will be having a Q&A at the conclusion of the presentation. Please use the chat for your questions. And now it is my pleasure to tell you about our speaker this evening. Professor of Medicine at Dalhousie University School of Medicine in Halifax, and a seasoned emergency medicine physician, Dr. Pat Croskerry is a world-renowned master diagnostician. An expert in clinical reasoning, Pat Croskerry has spearheaded the most challenging journey in medicine in diagnostic era, and that is to recognize the presence of cognitive bias and to acknowledge how dangerous bias is if left unrecognized. His new book, which you can see here up on the screen before you, The Cognitive Autopsy, is one riveting read, particularly valuable to physicians throughout every stage of their careers, and most especially while in training. I'd like to read you a snippet from a review of the book, The Cognitive Autopsy. If you wish to travel to a new place, help is available everywhere. But really, nothing beats finding a local guide, someone who lives there, knows the land, its people, culture, and how things work there. Well, that's exactly the role that Pat Croskerry plays in The Cognitive Autopsy. He's our guide to the still emerging arena of understanding diagnostic error. Pat has spent a long career working on the front lines in emergency medicine. He knows this place like the back of his hand. The Cognitive Autopsy is a unique and fascinating collection of the cases that span the spectrum of diagnostic error. Each one is its own self-contained story, rich with lessons of cognitive and affective biases. Stories are powerful, and it is said that stories may be how our knowledge base is organized. A diagnosis is itself a story that flows from the patient's story. And now let's stay in that flow, as I am ever so truly honored to introduce to you Dr. Pat Croskerry.
Great. Thanks, Jerry. Hi, everybody. Pat Croskerry here up in Eastern Canada, where top right-hand corner as you look at the map, that's Halifax in Nova Scotia. And I want to thank Jerry Donahue in particular and Empro for facilitating this. Essentially, the book has been out now for a couple of months, and I'm pleased to say that it seems to be hitting a nerve among physicians and clinicians and medical students. At least one school has adopted it for a book for their curriculum that addresses clinical decision making. Clinical decision making isn't an easy area to work in, and people shy away from it for various reasons. But I want to try to illustrate, I think what the book is aimed at is trying to give us a deeper understanding of what we're actually doing when we're making decisions. Most of us take it for granted that we can make decisions about patients once we hear a little bit about what's going on. But I want to kind of demonstrate that this is a process that's extremely vulnerable to error. By way of introduction too, I'd like to point your attention towards this guy up in the top right-hand corner here. That's the icon for our critical thinking program in the medical school, and it's actually a scarecrow. These four characters are all very well known to you. They're all missing something. This guy on the left is missing courage, which is essential if you're in the business of being a lion. This Tin Man is missing a heart and doesn't have any feelings. This young lady misses Kansas. The dog misses this young lady when she's not there. And this guy here is a scarecrow who thinks he's missing a brain. And so this became the icon for our critical thinking program in undergraduate medicine here, because what we wanted to emphasize was that all of us do in fact have a brain, and the scarecrow discovers that he does in fact have a brain when the movie is almost over. It's not our brains or our knowledge that is deficient usually when we make mistakes in clinical medicine, in clinical decision making. What the problem is lies with the way that we use our brains. It's how we think rather than what we know. And most medical students are extremely fearful that they won't know enough information by the time they graduate from medical school. In fact, knowledge, the knowledge basis of anybody graduating from a Western medical school is fine. What gets them into trouble is the way that they use their knowledge. And so this is where it starts. It started for us here. This is a graphic showing from a study by Macri and Daniel that was published in the British Medical Journal in 2016. You may have been aware of this at the time, but they made the outrageous statement that medical error was actually the third leading cause of death in the US. This was based on data from the CDC, the National Vital Statistics System, for the year 2013. Heart disease, not surprisingly, was number one with 611,000 deaths. 585,000 were due to cancer, and medical error was put at about 250,000. COPD was next, then suicide, firearms, motor vehicles. But some people said immediately that this was an exaggeration, this was an overestimate, that medical error couldn't possibly be responsible for that many lives. In fact, some people, including myself, think it's an underestimate, that an awful lot of people do suffer from mostly, the thing that mostly causes death is diagnostic failure. And three next bullets, please. The study that caught a lot of people's attention, well, it was by Lucian Leap, Don Berwick, and David Bates, and it wasn't actually a study, but it was an estimate of the number of preventable hospital deaths due to diagnostic failure annually in the US. These are people already in hospital, but die from diagnostic failure. And they put that number at 40,000 to 80,000. Work that's been done since suggests that it's much more likely to be 80,000, up at the top end of this estimate. Next slide. And David Newman-Toker, who's the lead for the Society to Improve Diagnosis in Medicine, has identified diagnostic failure as the biggest problem in patient safety. The overall diagnostic failure across the board is estimated at about 15%. So 15% of the time, we're getting the diagnosis wrong. And sometimes that will be inconsequential. We may say that somebody's got a bacterial infection where it's a viral infection. That is actually a diagnostic failure. But we're thinking mostly about usually when things go wrong, we're thinking more about misdiagnosing chest pain, say, as having a musculoskeletal origin rather than a cardiac origin, or missing a pulmonary embolus as a reason for being short of breath. And this pie graph shows the work that was done by Mark Graber and his group down at Stony Brook in Long Island. And they looked at the 100 consecutive cases of diagnostic error, diagnostic failure. And they had medical experts and also psychologists, cognitive science psychologists working on this. And they tried to identify what the primary source of failure was in each case. 7% of the time, they couldn't really say for sure what it was, and they just left that at 7%. This was a no fault, couldn't blame anybody for it, couldn't blame any circumstance for it. The next section is errors due to the system, and I'll say what these are shortly. But that came out to about 20%. This bottom right segment is cognitive error, and this is just straight thinking errors, nothing else, just problems with people's thinking. That was put at about 28%. And then this segment over here on the left is both system and cognition, and that was about 46%. So if you put together that one and the cognition one, it suggests that how physicians think is involved in about 3/4 of all diagnostic failures. And other studies have supported this and have even put the estimate higher. Next slide. This is just a kind of explosion of words which are associated with systemic failures. And you'll be familiar with most of the things here. Interruptions, distractions, normalization of deviance is when we do something to take a shortcut, an unsafe practice that we do it so often that it eventually becomes normalized. Delayed access to certain resources in the environment, in the medical environment. The electronic medical record, communication issues, not enough time, fatigue, things getting lost, and so on, expert unavailable, poor feedback. All of these things are regarded as system errors, but of course a lot of them are mediated by the things that individuals do, people do, but they're generally regarded as things outside of the human cognitive control, put it that way. Next slide. And next, that's it. So it does vary by specialty, the diagnostic failure rate. Dermatology, the next one, radiology, and anatomic pathology are all regarded as kind of visual specialties. And the error rate there comes out quite low at about 1 to 2%. But down here, internal medicine, family medicine, and emergency medicine, this is where the bulk of patients are seen, obviously, anyway, and where there is a higher level of uncertainty. And here, the diagnostic failure rate is put at about 15% plus. Next slide. So we were aware of this, and we've been working on this for some time, and we decided to start collecting cases which had unfortunate diagnostic outcomes. And this wasn't systematically done. We just, every time an interesting failure came up, we just said, we'll record that. And we developed a sort of teaching manual for medical students that we could use these cases to illustrate to them how these things were going wrong. And we collected these cases over about a 5 to 10 year period, myself and another guy in emergency medicine. He was running another department. Next slide. And straight off, we saw that things fell into 3 major groups. First of all, the knowledge-based errors. This was just that the physician perhaps didn't know enough about the problem that they were dealing with. And these are actually extremely uncommon. The second group are error-producing conditions, which are things like cognitive overloads, interruptions, stress levels, sleep deprivation, all those things. And there were quite a few of those, and we logged them all, and then that we could see. And then finally, thinking failures, which were mostly attributable to biases in the way that people think. Now, when I say biases, I don't mean, I don't want it to sound negative, like racial bias or obesity bias or something obvious like that. But these are just cognitive failings in the normal human brain that can lead to people making mistakes in their judgment and decision making. Next slide. So what did this cognitive autopsy show? Next. First of all, it was a detailed cognitive analysis. I mean, we took these cases apart, interviewed the physicians, analyzed the conditions at the time under which the case occurred, and we did it for 42 cases from emergency medicine. Next. And they didn't all cluster into sort of cardiac problems or orthopedic problems or anything in particular. There was, and I'll go through the list of what they looked like, but there was a rich variety of clinical diagnoses from all disciplines. Next. As I said, there were actually few instances of true knowledge-based errors. It is not usually, for a clinician who's finished their training, it is not a lack of knowledge that leads you into error. Very, very rarely. Next. There were 43 instances that we could identify of obvious error-producing conditions, and I'll show you what those are. Next. We found that biases are extremely common. We identified, according to the definitions that are in the psychology literature and in the medical literature, we identified a total of 232 instances. Next. There were usually about half a dozen cognitive biases associated with each case. So they don't just occur in isolation, usually about a half a dozen. Next. The cognitive errors outnumbered the knowledge-based errors about 40 to 1. So if you want to, if educators want to focus on an area where you might improve decision-making, the first place to look at is how the brain thinks and the cognitive errors that it's vulnerable to. Next slide. Next, good. Sorry, the next bullet. Oh, sorry. Okay. This is, I didn't realize we'd finished with the last slide. This is a breakdown of the discipline of these 42 cases. There were 19 from medicine. Next. 6 from neurosurgery, 5 from surgery, 3 from ophthalmology, 3 from orthopedics, 3 from OBGYN, 3 from psychiatry, and 2 from neurology. And this was a bit of a surprise. I mean, we certainly didn't expect to find neurosurgical problems outnumbering, say, urology problems. But this was the true breakdown, and maybe we'll learn more about that later. Next. So what were the diagnoses? We'll go through these quickly, but just to give you some idea of what was actually involved. The first case was hypothermia. Next, then a salicylate overdose. That's an acute salicylate overdose. Traumatic rupture of the spleen. Upper respiratory tract infection. Pulmonary embolus. Cauda equina syndrome. Fairly rare, but it happened. Subarachnoid hemorrhage. Medication errors were quite common. Medication errors are probably the most abundant error in medicine, but funnily enough, they don't often lead to diagnostic failures. Methanol toxidrome, abdominal pain that wasn't recognized. Traumatic paraplegia following a seizure. Often when somebody has an epileptic seizure, we focus on making sure they didn't have any damage to their teeth or that they've maintained their breathing and so on. What we forget is that often people who have generalized seizures do have significant fractures associated with them. In this particular case, a vertebral fracture was missed that led to paraplegia. Next. Skull fracture and penetrating brain injury, that was an unusual one. Guillain-Barré syndrome, again rare, but that's one of the reasons it got captured. But it was there, and it just showed up out of the blue. Next, ophthalmic siderosis, somebody who had a rust ring in the eye that wasn't removed, had a metallic foreign body actually that caused a rust ring that wasn't recognized. Next, temporal lobe epilepsy that was misdiagnosed, aspiration pneumonia. An ectopic pregnancy, not uncommon, but actually the only one here. Imperforate hymen. The only time I ever saw it was in this series. Yeah. An acute inferior. This came up several times. Next. Ludwig's angina. Actually seen that twice. And a special wrist injury referred to as an intercarpal ligamentous injury. The next one, is aseptic meningitis, completely missed. Chronic salicylate toxicity, which is different from an acute salicylate overdose. Next. Non-suicidal self-injury disorder. This was a schizophrenic who was swallowing things and not telling us that they were doing that. Another case of splenic trauma. Next. Retinal detachment that was misdiagnosed. Hand fractures that were missed. Frontal lobe tumor, completely missed in a street person. Comminuted scapular fracture that was missed in the context of a clavicle fracture. Yep. Traumatic pneumothorax, missed in the context of something else. Another medication error, giant pulmonary bullae, which were misinterpreted as pneumothorax. Next. Another medication overdose, a medical procedure error, alcoholic gastritis, misdiagnosed, tricyclic overdose, misdiagnosed, and another acute inferior, a urinary tract infection that was missed, herpes zoster that involved the eyes, renal colic, the stone was completely missed on the x-ray, profound hypoglycemia. This was a lady who had a blood sugar of 0, and it took us a while to discover that. Next, and a person with a C1 vertebral fracture who actually came into emergency 3 times before it was picked up. And it was one of these skiwara injuries, spinal cord injury without evidence of radiological evidence. But it was eventually picked up on a CT scan. And she was very lucky that this didn't completely sever her spinal cord. So you can see there that these are not trivial cases. In fact, many of them are sort of out of the ordinary, but they were collected in a normal general medicine, general hospital, and they all happened. Next slide. So the error-producing conditions that I talked about, these will get you into trouble. There were altogether, I think, about 40 of them. But number 1 was fatigue. We do underestimate the effects of fatigue. Number 2 was handover errors when you switch the care of a patient to a colleague or you're ending your shift. Next one is sleep deprivation and sleep debt. This is probably more significant than we gave it credit for, but these were cases where it was distinctly identified as contributing to the error. Next. Being distracted. Next. High stress situations. When the stress level is high, the quality of decision making goes down. People doing corridor consultations, which is not going through the usual workup for a patient and just assuming you know it, just through a quick glance at something their colleagues got. And just to emphasize it, we had a retinal detachment was missed in a nurse who was complaining of conjunctivitis, and the emergency physician colleague she was working with thought that it was an allergic conjunctivitis. Her retinas were actually detaching in both eyes. Next was time pressure errors when there's just far too little time available. Yeah, next. Being cognitively overloaded. You can be cognitively overloaded without being particularly busy if you've got 2 or 3 cases that require an awful lot of thinking. Next. RAKITO is an acronym for Resource Availability, RA. CQI is Continuous Quality Improvement, and TO is Trade-off. So it just says that as your resources become stretched and limited, and COVID would be a good example, your ability to provide continuous quality improvement is traded off as those resources are stretched. Next. Rapid task switching, which is the correct name for multitasking. Next. poor feedback, next, and system failures, various forms of system failure. So the system, not really, these are kind of system-related issues, but they're not as discrete and obvious sometimes as cognitive biases. Next slide. Oh, there was one more there, a time delay error, where that particular case was where a result got held up and led to all kinds of problems when people started making other interpretations. Next slide. The top 12 biases, medical students get really concerned when we mention how many biases are. There's currently identified over 200. But in these cases, we identified a total of 24 in the 42 cases. And these were the top ranked 12. Anchoring, locking on to particular features of a presentation very early on when you first see it, was the biggest, most common error, and occurs right at the very beginning too. Diagnosis momentum is when diagnosis gathers momentum without gathering evidence usually. Confirmation bias is looking for evidence to support something you already believe rather than look for disconfirming evidence, which is far more useful. Unpacking failure, I was surprised that this came out number 4, but it is simply the failure to unpack enough information in the presentation of a case, people cutting off the collection of information at the outset, and that was number 4. Search satisficing is when what it sounds like when you feel you found something and you feel satisfied that that's the solution, and in fact there may be other things to find, but you've already called off the search. Framing is when the thing is set up in a particular way. The patient can do it to you. That's called patient cueing framing, or your colleague can do it to you, or sometimes you can even do it to yourself. Ascertainment bias is when you see what you expect to see. The psych-out errors are a whole collection of errors associated with psychiatric patients. For those of you who work in emergency, a psychiatric patient is more likely to be misdiagnosed than a non-psychiatric patient. Fundamental attribution error is when you attribute some finding to the disposition of the patient rather than the disease itself. People will develop antipathy towards patients. Borderline personality disorder is one of them, rather than to the actual underlying disorder itself, which is actually, a psychiatric diagnosis. Triage queuing is obvious. It's what the people at triage tend to do. They send people to different parts of the department, leading to the expression geography is destiny. They send people to the trauma room, the cardiac room, the resus or low priority beds, but anyway, it's basically the triage of where the patient goes, which often determines their fate. Premature closure is shutting down the diagnostic process too soon. Omission errors, which outnumber commission errors. Omission errors are just failing to do something. Next slide, that should have been done. Just for a bit of fun, we did this. We took the start of each case and we looked at which biases emerged in what order. So the first bias is here. This is a line going across the horizontal axis here. This is the first, second, third, fourth, fifth, and sixth biases to emerge. So each bias was given a score according to the position that it took in each of these 40-odd cases. Number 1 was anchoring. So the first bias that you engage and the first bias that is most likely to come up is anchoring, and that's just locking on to the presenting features of the case and failing to adjust them in any way. Framing, ascertainment were both up there fairly early on, availability, triage queuing, and so on, all the way through to some fairly less common biases up the end here, who don't usually appear until later in the diagnostic process. This was quite fun, but it sort of shows that what some people are saying now, that biases have relationships with each other, like anchoring may influence something that comes later, and triage queuing, of course, can influence things. But this is a kind of new ground. But there are a couple of people working on the relationships between bias and have identified certain biases of having knock-on effects, like they talk about cascade biases and snowball biases, but they get going early on and then they lead to other problems later on. Next slide. The error-producing conditions. Next. We identified these as, for example, cognitive overloading. Next. These are general conditions. Now, high stress situations, interruptions and distractions, fatigue effects, sleep deprivation, sleep debt, and negative mood. When you've got any one of these 6, you have an increased tendency to make mistakes. But this is slightly different from the other slide I showed, which were specific error-producing conditions. These are general phenomena associated with any medical work environment. Next slide. So we're pretty well done there. I just want to summarize the main points. The first is that the principal factor in failed clinical reasoning, the barometer of failed clinical reasoning, is diagnostic failure. This is the kind of canary in the coal mine. Next. The current estimate of diagnostic failure is 10 to 15% across the board. Next. The sources of failure are the system about a quarter of the time and the individual about 75% of the time. So most of the time, the individual clinician is responsible for diagnostic failure. And even where the system fails, the individual is often still expected to show resilience and recovery from that. The principal source of individual failure is how we think, and not so much about what we know, but how we think is the critical thing. Next. The main factor that determines how well you think is your rationality. Next. Your rationality is determined by your vulnerability to these cognitive biases, which, as we've seen, are abundant. Next. Medical education needs to promote medical rationality, and that sounds like a simple thing to do, but it's extremely complex. But if we're going to fix this problem, this is what we have to do. Next. We can all improve our thinking skills with training. We're not scarecrows. We've got the brains, and if we train the brains, we find that they work quite well. Next slide. And this is often said, and I think it's true, most of us don't reach our potential for rational thinking. There's numerous studies done around the world which show that a small amount of coaching in thinking improves critical thinking by 10 to 15%, a relatively small investment in training people to think in different ways. Next slide. That's it. This is just a point to make about this whole thing, that there is actually an ethical imperative to think about the way we think. This was by 2 ethicists from Cornell, Meredith Stark and Joseph Finns. Next slide. Next slide. And next slide. And they put an emphasis on this. What they said was, an expanding body of scholarship, that is, accumulating medical evidence, has further elucidated the causes of medical error, right? We knew there was medical error, but now we know a lot more about what the errors are, including the considerable extent to which medical errors, particularly in diagnostics, may be attributable to cognitive sources. Insufficient progress in systematically evaluating and implementing suggested strategies for improving critical thinking skills and medical judgment is of mounting concern. So there is, and next slide, this is no longer an option. This is something that we clearly have to consider. And the final slide. Next slide. That's it. Thank you. Thank you.
Thank you so much, Dr. Croskerry. Some questions have come in. They've been directed privately to you, so I have control over that, so I've taken them here. Can you hear me well? I'll read you the first question.
Yes.
Okay, it's, well, first it says thank you. We all know doctors who are self-described physicians with quote unquote no bedside manner.
Yeah.
We'd like your take on this doctor. Is he ignoring, or she, I guess, this is he, ignoring biases on a daily basis?
Yeah. That interesting. That's a question that comes up quite often. And people have said, what do you think about this? And I can remember people saying things like, bedside manner is inversely proportional to diagnostic success or something. But what they were saying was that those people who put effort into developing bedside manner actually were compensating for their overall competence, which wasn't a very nice thing to say. But what it was doing in a way was reinforcing something that medicine does quite well, which is to insulate itself, and some doctors do it very well. They insulate themselves against other things that are going on, like the patient's feelings and the patient's disposition and the patient's concerns, and sort of stick to the book and the application of this kind of rigid analytical knowledge. I don't like it particularly, but there's a lot of things in medicine you can quarrel with. Let me give you a quick personal story just to illustrate my approach to it. I was scheduled for some surgery myself, and my family doctor, who we know each other quite well, said, look, who do you want me to refer you to? And I said, I don't want to have anything to do with that. You make the decision. He said, okay, well, I'll put it this way. Do you want somebody who's got a good pair of hands, or do you want somebody who's genial and friendly and you'll feel comfortable with? And I said, I want the guy with a good pair of hands. So essentially I was saying that bedside manner didn't matter much to me. But there's no question that cognitive empathy and bedside manner are important parts of this art plus science that medicine is supposed to be. We can't just ignore the art side of medicine. There's a lot more to it than simply the knowledge of what you have to do. And what's interesting is that we showed in the cognitive autopsy series that medical knowledge was not much of a factor. I mean, having good hands in the OR might be, but medical knowledge is not that much of a factor. So why not have doctors who are knowledgeable and can make patients feel good? As I got older in my profession, it came to mean more and more to me what the patient was thinking and feeling. That's a good question.
Good question indeed. Thanks for such a great answer. We have just a beautiful variety of disciplines represented in the audience tonight. And so this question comes from somebody who begins with, I am not a doctor. I do work in the ED though. I see from your slide, if I'm understanding you correctly, that anchoring seems to be most frequent. What can I do if I recognize anchoring?
Well, again, an important question, and perhaps the question should be, what can anybody do when they recognize anchoring? Because anchoring itself is not a bad thing. Just think about it. If somebody comes in who's short of breath, then your first approach is not to examine the abdomen or do a head and neck exam. If they're short of breath, you examine the lungs first. You listen to the chest first. You try to discover what's going on in the chest, because that's where the anchor is telling you that's where the solution most likely is. But the error, as it was originally described by the cognitive scientists, was nothing wrong with anchoring, but you've got to be prepared to adjust your anchor. And that's the biggest mistake that people get into. And I've seen this so often in my own practice, that people latch on to something very early on. So all of us should be saying, what's my own vulnerability to anchoring? Because that's the most common error we're going to make, and it's the one that's going to get us into the most trouble. And I think the approach that we all should take is, don't trust your first impressions. Don't trust the first idea that comes to you. And most of us with gray hair have learned that that's the right way to go. You mustn't trust your first impressions. And the first question you should ask yourself, perhaps, is, what else can this be? Okay, I'm pretty convinced that this guy's got musculoskeletal back pain, but what else could be on the differential diagnosis here? So to avoid the anchor, always try to consider other possibilities. And if you see a colleague doing it, you know, in as nice a way as possible, try to steer them away from the anchor and say something like, you know, I saw something just like this once and it turned out to be so-and-so, something completely different. So try to alert them to the possibility that the anchor can be misleading.
Well, that's a great response. That sounds like a response that would be well received, likely physician to physician, possibly. You could see that being tough if the person was a non-physician saying to a physician, I heard about this case once, and it turned out this way. With all of this, is just a question coming from me, and then there's another question before we start to give away the book. Do you in your emergency department have groups or anything along the lines where people actually are taught the biases, how to recognize them, and so that, or are you kind of a fish out of water there, where you're looking at everything differently than everybody else?
No, I'd say, I mean, I sometimes complain that we have a critical thinking group, a critical thinking advisory group, and it's mostly made up of emergency physicians, but there's also ethicists on there, internists are on there. And we discuss the whole nature of the problem, and mostly because we are expected to give input to the undergraduate medical program and the postgraduate program, and also continuing professional development as well. But mostly our emphasis is on undergraduate medicine. So we have a undergraduate critical thinking website, and this advisory group tries to steer the way we give input to the educators in the medical school. So you could not go through the program here at Dalhousie without a fairly strong exposure to the concept of cognitive bias and how it can interfere with clinical reasoning. So and as I say, as with anything else, you get ardent supporters, you get people who feel extremely strongly about it, and you get other people who are a bit lukewarm. I know some people in medicine who absolutely deny the existence of cognitive biases and say that they have no impact on what we do, which is, to me, it's a bit like saying there's no law of gravity. You know, we couldn't get by without gravity, and human beings couldn't get by without cognitive biases. But they seem to affect everything we do, you know, from events on the world stage to why countries go to war, and the behavior of the World Bank, and all the way down through to the guy, I mean, if it's down, if that's the direction, but I mean all the way out, if you like, to practices like mechanics who fix your car. Everybody is vulnerable to bias, and we're all vulnerable to the same kinds of biases.
So this makes perfect sense of how passionate you are about the message in this book getting into the hands of the young doctor in training, so they begin early. And it sounds like it's happening in Tallahassee. I don't know in the States if we've been as lucky to have that yet. We're getting close on time, so I was going to tell you what the last one is. It's more of a comment than a question, which is, This has all been extremely stimulating. I learned a lot, yet I feel I have so much more to learn. I do not believe you allocated enough time for this presentation. Would Dr. Croskerry agree to returning for a part 2?
Yes. I usually get criticized for not saying enough, for talking too much.
Maybe we didn't give you enough time here. We were.
Well, this was actually, yeah, this was our second book on the diagnostic process. The first one, the one that was written before the cognitive autopsy, was a very detailed look at how people make diagnoses, and it was a bit dry. I mean, people who are very interested in the area would have got a lot out of reading it from a theoretical standpoint, but we felt we needed something like the cognitive autopsy. It's like, I don't know if anybody's ever read the Canterbury Tales or things like that, where you have these individual stories that go along and they all tell their own story. And I think that's one of the great features of medicine, that it's still very strong on narrative. And we learn a lot from narratives. We learn a lot from stories. And it's fun. You know, it is fun to read a coherent story about how something worked out. And the medical students tell us that they actually learn quite a bit of medicine in going through the different cases. You know, things like not the obvious things, but things like
your first case in the book, that was hypothermia. That certainly wasn't.
Yeah,
it wasn't the first thing you think of.
Yeah, in Canada, people talk about hypothermia all the time, but you very rarely see it in emergency. And when that one came in, we all missed it. But cases like Guillain-Barré syndrome, you might, I've only ever seen that 3 times in my career, but after you've read that case, you probably won't forget it. And the same with, you know, some of the other, you know, abscesses on the spinal cord and stuff, that, and broken necks with nothing showing on X-ray. All of those are brilliant lessons to learn from everyday emergency medicine. This was a general hospital. This was not a teaching hospital. This was a run-of-the-mill, kind of backwards. They won't like me for saying that, but it wasn't even a teaching hospital. We used to get residents come over occasionally, but this was not the ivory tower. But these cases all came through a general hospital emergency department.
What can we possibly say to Dr. Croskerry? You never cease to amaze us. You really are just an incredible individual to know professionally as such a scholar and a thought leader. And you're so good to PRI, is such a good friend to us, and we so love our relationship with you. So we will have you back. We got you on, you know, here in front of everybody. We have a lot of witnesses. We'll get you back. We'll spend more time, but you have enlightened and stimulated us so. And I hope people read the book, because I found it that it's so easy for me to recall. You're exquisite in your detail, and it comes right back to you. The stories in the book just stick, and it's a wonderful learning experience. So until the next time, I think the way we should say goodbye to you tonight is a kind of a fun way to do it when we do programs virtually. If everybody, we have a large crowd still with us here, which is terrific that they stay through the giveaway of the books. Everybody just unmutes at the same time and said, good night, thank you, goodbye. So we'll do that. Everybody on the count of 3. 1, 2, 3. Goodbye.
Good night. Thank you.
Thank you.
Bye, Dr. Croskerry.
Thank you.
My pleasure.
I think you saved a few patients' lives from my end, because I've heard you before. I really do. I stop and think much more since I heard your talk, and I really want to thank you for it.
Oh,
Thank
how
you.
nice. Thank you. Thank
Bye.
you to our whole audience. Wonderful. We'll see you again.
Bye.
Good night now, everybody.